My name is Charl Els and I'm a clinical professor in the Department of Psychiatry, and I'm appointed as a physician educator in the Division of Preventive Medicine at the University of Alberta. This session focuses on the occupational impact of bipolar 1 and bipolar 2 disorder. Thank you to the Workers' Compensation Board of Alberta for making funding available for this project. There are no conflicts of interest to declare, and the opinions expressed in this presentation reflect those of the speaker and not necessarily those of any collaborator or funding agency. This session provides a brief overview of the features of bipolar disorder, including causation, prevalence, diagnosis and treatment, as well as prognosis. It focuses on the occupational impact of bipolar disorder on specifically capacity, risk and tolerance. At the end of the session, participants will be able or will be equipped to recognize bipolar disorder as an occupationally relevant condition. Also describe the impact of the condition on capacity, risk and tolerance. And thirdly, to broadly outline evidence-based interventions to achieve maximum medical improvement. What is bipolar disorder? Well, bipolar 1, or what we used to refer to as manic depressive disorder, represents a mood disorder characterized by the occurrence of one or more manic or mixed episode, and where major depressive episodes may have occurred in the past, where the individuals experienced at least one major depressive episode and at least one hypomanic, not manic, episode. The diagnosis of bipolar 2 disorder is offered. Also, in bipolar 2 disorder, there's an absence of psychosis or the need for hospitalization. Once psychosis or mania occurs in this context, we can no longer diagnose bipolar 2. With bipolar 2, unlike what's the case with bipolar 1, the episode is not severe enough to cause marked impairment in social or occupational functioning or to necessitate hospitalization. Despite this, the DSM suggests that bipolar 2 disorder is no longer thought to be a milder condition than bipolar 1 disorder, largely because of the amount of time individuals with bipolar 2 spend in depression, and secondly, because of the instability of mood experienced by individuals with this disorder. It's typically accompanied by serious impairment at work and social functioning. What causes bipolar disorder? Although there's no single proven cause for bipolar illness or disorder, we know that the underlying changes in the biochemistry in the brain responsible for symptoms, it's likely predominantly genetically determined. Like with most psychiatric conditions, the biopsychosocial model may apply with predisposing factors, precipitating and modulating factors. Stressful events may trigger manic episodes in vulnerable individuals, and sleep deprivation may actually do the same. Alcohol and drugs, certain antidepressants, and several other drugs and medical conditions can also result in secondary mood symptoms. The DSM suggests that the 12-month prevalence for bipolar 1 is about 0.6% and up to 2.4% in some settings, while bipolar 2 disorder ranges from about 0.3 to 4.8%. Bipolar is equally common in men and women, but rapid cycling is more common in women. The diagnosis of bipolar is made by taking a comprehensive history and by performing a physical examination to rule out medical problems that may be causing or contributing symptoms. For the diagnosis itself, the physical examination is usually non-contributory and special investigations are conducted only on the merit of positive findings and to rule out physical conditions. An evaluation that includes psychological testing, which may assist in the diagnosis, is recommended, and that includes the use of rating scales, for example, the MDQ. And this is used not only for the diagnosis, but also for the severity as well as the response to treatment. There's no single definitive diagnostic test, and the diagnosis remains clinical on the basis of the symptoms, the course of the illness, and usually the presence of a family history. Then the symptoms should meet the diagnostic criteria for bipolar disorder. And in order to do so, we look at symptoms meeting criteria for depressive episodes, mania, and or hypomania. Using the criteria in the APA's DSM-5 allows for this diagnosis to be made with a reasonable degree of certainty. And for a diagnosis of bipolar 1, it's necessary to meet the following criteria of a manic episode. The episode may have been preceded and may be followed by a hypomanic or major depressive episode. In the DSM, the manic episode is described in criterion A as a distinct period of abnormally and persistently elevated or expansive or irritable mood and abnormally and persistently increased goal-directed activity or energy lasting at least 1 week, and which is present most of the day, nearly every day, or any duration if hospitalization is necessary. With bipolar 2, unlike the case for bipolar 1, the episode is not severe enough to cause marked impairment in social or occupational functioning or to necessitate hospitalization. For hypomanic episode symptoms, unlike manic symptoms, it should last only 4 consecutive days. For either of these conditions, either manic or hypomanic, 3 or more of the following are present. 1. Inflated sense of self-esteem or grandiosity. Decreased need for sleep. In other words, the individual feels he or she is rested only after a few hours of sleep. Being more talkative than usual or experiencing a pressure to keep talking. There's flight of ideas or the subjective experience that thoughts are racing or chasing each other. Distractibility, in other words, attention too easily drawn to unimportant or irrelevant external stimuli. And this could be objective or subjective. There's an increase in goal-directed activity, either socially, at work, sexually, or psychomotor agitation. There's excessive involvement in activities that have a high potential for painful consequences. For example, engaging in unrestrained buying sprees, sexual indiscretions, foolish business investments, and many others. And for a major depressive episode, which forms part of the condition, the criteria apply, and these are covered in a separate video. And there's a list, of course, where at least 5 symptoms need to be met within a period of the same 2 weeks. It's important to rule out medical conditions and substances that can cause or mimic the clinical features of bipolar disorder. Substances that are often associated with this condition include alcohol and illicit drugs, for example, stimulants like amphetamines, cocaine. There's also drugs like the inhalants, PCP, opioids may also be associated with secondary mood symptoms. And there's a range of psychiatric prescription medications that can be associated with bipolar. For example, barbiturates, benzodiazepines, SSRIs, SNRIs, methylphenidate, some of the older antipsychotics, some somatic therapies like light therapy can also be associated with the triggering of hypomanic or manic episodes and symptoms. So there's a long list of other medications, non-psychiatric, which include analgesics, antifungals, anti-neoplastic drugs, cardiac drugs, endocrine agents, and some neurological agents, which may also be associated with secondary mood symptoms. The physical examination is usually non-contributory in the diagnosis of bipolar disorder, but it serves to rule out medical conditions that may mimic or may cause these particular symptoms. Examples of medical conditions include neurological conditions like trauma, tumor, cerebrovascular accident, dementia, epilepsy, MS, other medical conditions like endocrine conditions like Cushing's, Addison's, hypo and hyperthyroidism, and then further, some other medical conditions include infectious diseases like HIV, tertiary syphilis, toxoplasmosis, to name only a few, that can also present with symptoms that mimic bipolar disorder. Certainly specific testing is requested only based on ruling out secondary contributors. For example, if a brain tumor is suspected, a CT and an EEG may be required. Regarding the ability to work and the impact on occupational variables of the risk, capacity, and tolerance, certainly individuals with an acute manic episode may be at acutely increased occupational risk due to a lack of insight, impairment in judgment, lack of predictability of mental status, the presence of impulsivity, anger, violence, and the high comorbidity with drug and alcohol abuse also pose a potential risk, especially in safety-sensitive settings. Not only is risk increased, but capacity impairment can be associated with certain more severe episodes of mania, as well as more severe depressive episodes. The hypomania typically does not result in marked impairment in social or occupational functioning. Importantly, the medications used to treat hypomanic or manic episodes may be sedating and may also be impairing and may be relevant in occupational safety-sensitive settings. Occupational tolerance may be adversely impacted by the condition, but this usually improves with treatment. And when reasonably controlled, persons may be working or may work in a non-safety sensitive setting, but for safety sensitive work, an extended period of stability, usually in excess of 1 year, is required for bipolar 1 disorder. For bipolar 2 disorder, depressive episodes tend to be the more impairing component. As stress and sleep deprivation can trigger manic episodes, bipolar disorder individuals may actually be precluded from working in settings where there's rotating shift work expectations. Treatment of bipolar disorder consists of medication and psychotherapy. Medication forms the mainstay of such treatment, and several classes of such drugs is available. It includes sedatives, lithium, valproate, lamotrigine, carbamazepine, second-generation antipsychotics. At times, combination therapy is required, and augmentation with an antidepressant, anxiolytic, or an anticonvulsant may be indicated. Sedatives are commonly used for short-term control of some acute manic symptoms, such as agitation or sleeplessness, that are core features of mania. Bear in mind that the lifetime risk of suicide in persons suffering from bipolar disorder is 15 times that of the general population, and the DSM-5 reminds us that bipolar disorder may account for 1/4 of all completed suicides, so certainly a great degree of attention is warranted. Medication use is not only indicated for the acute stabilization, but also for the maintenance, and this requires close follow-up. Emerging depressive episodes also pose an occupational risk and also warrant assertive treatment in terms of relapse prevention. Special attention to treatment adherence is indicated, as discontinuation of medication is often associated with an increased risk of relapse and the subsequent inability to maintain occupational engagement. A number of psychotherapeutic modalities are proven to assist with the overall management of bipolar disorder, but psychotherapy alone, in the absence of medication, as a measure to remedy occupational risk, is not recommended in this condition. In the refractory cases, ECT may be indicated. So part of the overall management of bipolar disorder is also to screen for co-occurring not only substance use disorders, but also for other mental disorders. And this would include anxiety disorders, ADHD, impulse control disorders, and it's difficult to distinguish between these at times. Metabolic syndrome and migraine also tend to be more commonly seen in bipolar disordered individuals. Maximum medical improvement is usually reached within a period of a month or two, but it may be longer. Certainly it takes substantially longer in order for them to return to safety-sensitive work. Bipolar disorder is a chronic and relapsing condition, and there's no cure for the condition. Prognosis varies greatly between individuals. Some people may remit spontaneously, but treatment reduces complications and disability, as well as the risk of suicide and substance abuse. Although some individuals may return to what's considered living a normal life, about half of people relapse within the first 2 years. If adequately treated and complications are addressed, adequate monitoring is in place, and reasonable treatment adherence is achieved, the prognosis is optimistic. If left untreated, the prognosis is guarded to poor, and comorbidities and complications may result in a rather complex clinical picture, one that's often not compatible with gainful employment settings. The condition may be associated with a risk of suicide, violence, and premature death, and warrants assertive treatment. Bipolar 1 and 2 are both chronic relapsing conditions that may significantly adversely impact work, especially in safety-sensitive settings. It's foreseeably associated with an increased occupational risk. Complications may be especially problematic, and screening and assertive approaches to such are required. Persons with bipolar disorder should preferably be stable for a period of at least a year prior to returning to safety-sensitive work. Special attention should be given to medication adherence, prevention of substance abuse, and prevention of suicide. We've included a list of resources which we think you may find helpful. Thank you. We look forward to your feedback and your comments. And please help us identify further topics for future discussion. Thank you.